Hello and welcome to section 4 of the Comprehensive Mental Health course for midwives. Section 4 is perinatal mood and anxiety disorders. We will be doing A, B, and C, mental health in pregnancy, mental health in childbirth, and mental health in the postpartum period. We are starting now with A. The agenda for this particular section, first we're going to go over prenatal depression and then prenatal anxiety. Then we'll talk about a bunch of screening tools, including safety and abuse screening tools. We'll move on to alternative treatments that are safe during pregnancy for mental health. Finally, performing a risk-benefit analysis with starting medications or avoiding medications when you're talking to your patient. So, prenatal depression. This is depression that takes place during pregnancy. Depression during pregnancy typically gets less attention than postpartum depression. People talk about postpartum depression a lot, and prenatal depression or pregnancy depression is actually just as serious, if not more, because it increases the risk of postpartum depression. So instead of just postpartum depression, a lot of women who have prenatal depression have prenatal and postpartum depression. It also becomes an issue for the baby as well. They're pregnant, the baby can be affected. Typically it arises through hormonal changes, psychological disturbances. Research does suggest that depression during the perinatal period is caused by a combination of genetic and environmental factors. Depression itself is a clinical diagnosis that's generally identified by negative emotions, sadness, loss of interest, and hopelessness. Loss of interest in things that typically made you happy, typically things that you like to do, or really loss of interest in anything. Hopelessness, feeling that going on is not worth it, being extremely sad for a long period of time, as opposed to just the baby blues, which also can happen during pregnancy. So being sad, blue, down, this is common because of all of the hormonal and the situational changes, social changes, environmental, and of course physical changes to your body, to one's body during pregnancy. This can make anybody sad, no matter what the situation is genetically or environmentally. Again, even if you have very low risk factors, it's very typical to have sadness during pregnancy. But when these feelings and these signs and symptoms are consistent for at least 2 weeks, then it is extremely important to reassess that behavior and that normal sadness, and to look at the potential for clinical depression during pregnancy. Depression affects about 1 in 10 pregnant women. So some of the signs and symptoms to help differentiate between depression and mood agitation or sadness, such as mild mood changes and feelings of worry and exhaustion, are when an individual feels over 2 weeks a loss of interest in work, no interest or loss of interest in preparing for the baby, and no interest or little interest in personal hobbies. A heavy feeling of guilt, worthlessness, hopelessness. Sleeping patterns that are more than normal or less than normal. So this does not mean in relationship to a physical pregnancy symptom such as heartburn, when the sleeping is increased or decreased based on nothing physically noted in the pregnancy. If it's more emotional and psychological, then it's worth noting, then it's a red flag. If an individual is having trouble paying attention or focusing or concentrating, and more than quote-unquote pregnancy brain, when it's a big deal, not, oh, I forgot the laundry list again, and oh, what was I supposed to get at the store, and things like that are not signs of prenatal depression. They are just signs that you're busy doing a lot of different things, and your brain is working overtime, and you've got a child that the body is producing. But when it becomes not paying attention, focusing or concentrating for a long period of time, having problems thinking through things, everything's being foggy, like a cognitive decline. When there's issues with making decisions or not caring about a decision, somebody says they're going to do something, your husband wants to buy a new car, which you don't do during pregnancy, probably a bad choice, but just throw that in there, and it's, the reaction is, okay, whatever, I don't care. Why don't we name the baby Harmonica? Okay, whatever, I don't care. When it's that total zone out and not caring, or not responding, or not even being able to make a decision, like it drives you crazy that you cannot figure out between Mike and Nelson, and it's not just to the point of, all right, we'll figure it out. It's more past that point and to something that is extremely bothering the individual. And then finally, being restless or slowed down in a way that others notice. So it's not just that, I'm pregnant during the summer, or I have more weight and it's hard for me to do things, or, I've got a little bit of a headache. It's an actual longer term being either restless, constantly doing things, moving like there's a motor attached to you, or just not wanting to do anything, feeling that you're not going to get up from the table after eating dinner because you just are slow and low and not motivated, and again, filled with worthlessness or hopelessness or helplessness. Risk factors associated with depression during pregnancy include an individual who had been previously diagnosed with a mental health issue. So before the pregnancy, they were diagnosed with depression or bipolar disorder or borderline personality disorder. Having that mental health disorder previous to pregnancy does increase the risk of depression. An uptake in life stress. So when something occurs during pregnancy that increases the stress aside from the pregnancy itself, maybe a spouse that's lost their job or can't make the mortgage payment or get kicked out of your apartment or find out that child got kicked out of school or something along those lines. But anything that would be considered life stress, when that has increased, it also obviously increases the risk for depression. So some of these are self-explanatory, but these are documented in several studies. And we also have the unintended pregnancy. Oh, I skipped lack of social support. So let me go back to lack of social support. In social support, as we know, is a very strong protective factor. So no matter what's going on, if a child or an adult or somebody going through any sort of stress, whether it's a mental health issue or not, when they have that social support, somebody to talk to, somebody to lean on, somebody to laugh with, somebody to take the focus away from the negative, somebody that can help them around the house, carry their laundry up or take them out for a cup of coffee, anything, or even listen, even just someone there to listen, that significantly reduces the risk. And of course, without that social support, the risk is inversely increased. So unintended pregnancy, as I was saying, now there are several studies that show unintended pregnancy as well as rape or assault pregnancy, which typically on those studies, the rape or the assault pregnancy does rank higher statistically as a risk factor. But in general, in unintended pregnancy, even for a married or, again, a non-married couple, which is statistically a little bit higher, unintended pregnancy is still a risk factor for developing depression during pregnancy. A lack of health insurance. Now, of course, because you cannot get to prenatal visits, or you may not be able to get support for mental health issues. So there's multiple reasons why, but just the lack of health insurance in general is definitely a factor. for depression. Lower income, able to get support for mental health issues. So there's multiple reasons why, but just the lack of health insurance in general is definitely a factor for depression. Lower income, so individuals that are either low socioeconomic status or rating under a certain amount of income per year tend to have more depression. So it is statistically associated with a higher outcome of depression in pregnancy. Lower education is as well. This doesn't have as much of a significant impact, but most studies do show that the lack of education or the lower end of the spectrum on maternal education is a risk factor in depression. And, again, we can do lots of studies and look specifically into each one of these risk factors. Could be because of less access to care, could be because of less understanding on health literacy, but just as it states, looking at the numbers, these are definitely risks. Single status, being single, being alone, not having a significant other to be with you during pregnancy, to attend prenatal visits with, to raise the child with, to have another income, whatever it may be. Individuals that are single have higher risk factors for depression. And then finally, poor relationship quality. So that could be anything from domestic violence, which I skipped that bullet as well, and I apologize, but it fits with this one as well. So it could be anything from domestic violence to just arguing and intimate partner violence, fighting, trauma, physical abuse, emotional abuse. They all fall under that, and they are high risk factors for depression during pregnancy. If prenatal depression is not treated, it does depend on how severe the depression is, but during pregnancy, depression has been linked to several problems with the baby, such as a baby not growing well in the uterus, or preterm labor, low birth weight, or babies that are small for gestational age, SGA. So that's when a baby is less than 1/10 of their percentile, whereas the low birth weight baby means that it's a baby weighing less than 5 pounds 8 ounces. Then we've got health complications for and at the birth, or for the baby at and after the birth. So right after the birth, at the birth, would be the low APGAR scores, problems latching. Some babies, you try to latch them while the placenta is still being delivered, and it has been documented with, again, these babies whose mothers have untreated depression during pregnancy, that these babies are more irritable, they have problems latching, they may be anxious, they can have multiple sleep problems, they also can be less active, have fewer facial expressions, and can be less interactive. So less active as in zoning out themselves in their cradle or what have you, and as opposed to interactive, which also tends to happen when they're less interactive. They may not respond to the mother's face right away. They may not look back, make eye contact as early as other babies. So these studies generally show that the more severe the depression is, the more intense the results are in the baby, the complications are in the baby. So ACOG, which is where a lot of this information came from, because of this, they do recommend that screening during prenatal visits is extremely important to help reduce the risk, because without screening, you may not pick up on some of the signs and symptoms. Often partners may notice that their pregnant partner is concerned about the baby too much, or concerned about, or not at all, like one extreme or the other, and they may mention that in a prenatal visit. They may seem foggy or zoned a lot, or follow tasks robotically. So these are things that, you know, you can hear and pick up. These are more of the signs that you can see as opposed to the symptoms they may be feeling in like a prenatal visit. But without actually doing the screening, it's hard to tell. So again, this is why ACOG says it's really best to do screenings and prenatal visits, because you could pick up on a lot of this that you may not see in a short prenatal visit. Treatment is available during pregnancy, and actually there's a lot of treatment available during pregnancy. Everything from support groups to therapy, different types of therapy such as cognitive behavioral therapy, IPT, which is interpersonal therapy, and psychotherapy, which is essentially talk therapy, as well as medications, psychopharmacological treatments, a combination of therapy and medications, and also brain stimulation therapies. So again, there are a lot of different options. CBT tends to be used more than IPT. CBT is like an inward reflection of oneself that they work with, whereas interpersonal psychotherapy works with the person responding to difficulties in relationships and life and interpersonal aspects. And so knowing that these are available, this is something that either you can help your patients with or recommend they work with other individuals, such as a therapist or psychologist or psychiatrist, especially if they're looking for pharmacotherapy. Prenatal anxiety is a clinical diagnosis that's generally identified by frequently occurring intense, excessive, and persistent worry and fear about everyday situations. And in prenatal anxiety, it's specifically, most of the time, it is specifically about the baby or about the pregnancy itself. Worry, stress, and fear are normal, but when they start to interfere with daily tasks and getting through everyday life, this starts to raise some concern. The risk factors for developing prenatal antenatal anxiety is very similar to depression, so such as lack of partner or social support, a history of abuse, personal history of mental illness, family history of mental illness, unplanned or unwanted pregnancy, adverse events in life and high perceived stress, and present or past pregnancy complications. Anxiety as a mental health disorder is one of the most common types of mental health disorders, and pregnancy increases the risk for developing mental health issues. So it's very important to be aware of these signs and symptoms, such as the individual being nervous or on edge frequently, having an uncontrollable sense of worry or dread, fearing excessively about things, including the pregnancy, the baby's health, the birth, maybe having strange dreams that are haunting you, finding it difficult or impossible to relax, feeling restless, hard to stay still or concentrate, like you're being run by a motor, feeling irritable, agitated, frightened, scared, excessive sweating, increased heart rate, tension, pain, numbness, or trembling in muscles. These are the most common types of anxiety disorders. There's the generalized anxiety disorder, GAD, and generalized anxiety disorder is when you feel anxious about a wide variety of things, and it occurs on most days: restlessness, cold sweaty hands, numbness, dry mouth, chest pain. Panic disorder is when there are attacks of intense feelings of anxiety that seem to be out of control, causing increased heart rate or increased breathing. Social anxiety disorder is when there's an intense fear of being in public or in being in social situations with fear of being judged or embarrassed. Specific phobias are fearful feelings about a particular object or a particular situation, such as a specific phobia regarding horses or planes, spiders, or being on stage. And then obsessive compulsive disorder, which is OCD, intrusive obsessive thoughts and fears about fears that you have to complete certain rituals or repetitive behaviors. There's also PTSD, but we will discuss post-traumatic stress disorder on its own. The risks of untreated anxiety are very similar to the risks with depression to the fetus. So that includes the fetus not growing well in the uterus, potentially preterm labor, low birth weight, small for gestational age, health complications for the baby at or after birth. So at birth, the APGAR scores, problems latching. In the first couple days after birth, you may see sleep problems, anxiousness. A lot of these can continue on. There's also been multiple studies showing a smaller head circumference, so that's related to brain size in babies whose mothers have had anxiety during pregnancy. Prenatal anxiety also affects the cortisol levels, so it directly affects the mother with increasing those cortisol levels and can cause obstetric problems that can lead to C-sections. The baby as well may have problems with self-regulation. It's been noted in multiple studies that procedures such as the heel stick procedure and early infant vaccinations, babies have had problems calming down from that and staying calm. Prenatal anxiety also affects the emotional and mental development in babies, so it's been seen that children whose mothers have been diagnosed with anxiety during pregnancy have had elevated cortisol, a lot of internalizing behaviors, as well as emotional and mental development stunts, lower mental development scores, etc., etc. So essentially, treating the anxiety is extremely important during pregnancy. So the next couple slides, we're going to be talking about depression and anxiety screening tools. We also have some slides about intimate partner violence and screening tools for domestic violence and abuse and what have you. The majority of these tools have been validated for pregnancy as well as the postpartum period. Just keep in mind that formal education and training may be required for the administration and the interpretation of these assessment tools that we have. So evaluators should refer to ethics, licensing, education, and training requirements before administering and interpreting these. The administering of self-administered tools, those are definitely something that can be given. Self-tests, for example, in a prenatal visit, a postpartum visit, just make sure it's the ones that once they return them, you have comfort in interpreting and evaluating. There are other tools such as the APDS that the training should be included for interpreting and evaluating in most maternal training. Maternal health training doesn't necessarily have to be a mental health setting or a particular psychiatrist or psychologist, again, focused on mental health, but these are not to be used as diagnostic tools. Again, they're more for screening and determining whether your patient needs further assessment and evaluation for mental health issues and whether you should refer out to a therapist and or psychiatrist. So these 4 tools here are for depression. They've been validated for pregnancy and postpartum. Center for Epidemiologic Studies Depression Scale, which is a brief, valid, and simple screening tool that can be used to identify pregnant women with the risk of depression. The PHQ can be used in pregnancy specifically as well as not during pregnancy. This is a 9 items. The PHQ-9 is a 9-item depression screening scale. Focuses on somatic symptoms. So we're looking at the body aspects of things. It's a reliable and valid scale for prenatal antepartum depression. It's good for an assessment and to help determine whether further help is needed. EPDS you should be familiar with. It's 10 questions focused on the symptoms that are common in women with depression and anxiety during pregnancy and the year following childbirth. This is a tool that's specifically for the pregnancy period and postpartum period. This is something that, unlike the PHQ, is not used when not in the childbearing year. Now, the EPDS has been validated. It's initially developed for postnatal, but it was validated for pregnancy as well. And then the BEC, just like the PHQ, does not need to be used in pregnancy, but also can be used in pregnancy. BEC Depression Inventory 2 is a brief self-report inventory. This is designed to measure the severity of depression symptoms. Now, these tools are for anxiety, generalized anxiety disorder 7, so the GAD-7. Again, this is something that can be used in and during the childbearing year, as well as not involving the maternal period. This is a brief 7-item diagnostic tool, and it focuses on excessive anxiety and worry about everyday events and activities. And then we have the PASS, which is specifically for the perinatal period. PASS means Perinatal Anxiety Screening Scale. This is a lot more in depth. This is not a brief scale. This is a thorough 31-item questionnaire. It was initially developed in Western Australia, and it's specifically to screen for a broad range of anxiety symptoms during pregnancy and the postpartum period. Now we're moving into the safety and abuse screening tools. As I mentioned before, the intimate partner violence, this is definitely something that can have an impact on many mental health disorders, specifically depression and anxiety, as well as others. Nearly 1 in 6 pregnant women in the United States have been abused by a partner. The risks of intimate partner violence statistically are significantly increased during pregnancy. Physical violence perpetrated by intimate partners is often accompanied by emotional, abusive, and controlling behavior. Again, that can lead to psychological and physical harm for both the mother and the baby. Here are some screening tools that can be used. SHARP is the Stalking and Harassment Assessment and Risk Profile. It's about 15 minutes. Most people can complete it online. Typically, if it's completed online at a visit, is most suggested because women do not feel comfortable at home for multiple reasons. So it's suggested that this can be completed in the office during a visit. It is free, confidential, it's quick. It's again about approximately 15 minutes, and then about a minute after completing the assessment, there's a narrative summary with steps that they can take. So this comes automatically from filling it out online. The Mosaic is a tool that addresses how a similar situation is to different situations. So it's kind of it rates it based upon a weighted scale showing the importance of the relation of the importance to certain situations that have happened or that are currently happening in a person's relationship. And then just like the SHARP, a detailed report is compiled and immediately sent to an individual. So again, this is something that can be completed online, and it's best if it's completed online at the time of the visit, so the individual does not feel as though they are uncomfortable or frightened to fill it out at home. It is online, but again, it is confidential, so it can be done anonymously. The danger assessment, the DA, is a great tool to help assist women and their providers to better understand the potential for danger and the level of risk. The danger assessment helps to determine the level of danger an abused person has of being killed by an intimate partner. And this is something that can be printed out and used with a calendar in an office visit. Typically, you use the calendar to help the individual understand the frequency of the abuse and raise consciousness to the victim. This type of assessment should be followed up with information for an advocate or a counselor. The DVSI is the Domestic Violence Screening Instrument. This instrument has questions primarily related to the criminal history of domestic violence and other violent offenses. This includes arrests, convictions, etc., restraining orders. And so this, of course, would be appropriate if there is documented criminal history, violent offenses, etc. So employment status, recent separation, things like that are also looked at. So this is really used as a statistical instrument. It doesn't require any inclusion of clinical judgment. This can be completed by anybody. It does not have to be completed by a mental health professional or assessed by a mental health professional. SARA is the Spousal Assault Risk Appraisal Guide. So it's a checklist, a quality control checklist, determines the extent to which a professional has assessed the risk factors. It's a crucial predictive importance to safety for the individual. Now, this is according to clinical and empirical literature. So this checklist has been designed with a background of the most important information that should be asked for assessing the risk. This is given for individuals that are suspected of being treated for spousal or family-related assault. The scores based on information from multiple sources. So this is something that a professional would most likely need to assess depending on the training that individual has. So RADAR, this is not a tool, this is actually outlines action steps that can be taken, and RADAR can be used by any professional. Doesn't necessarily have to be midwife or physician or even a mental health individual. RADAR stands for routinely ask, document, assess, and review. And this is something that should be part of any health practice or mental health practice. So routinely ask about partner violence in your practice. Bring it up, even if it's something that is done subtly. When you're doing the history and physical, throw it in there. When you're doing a checkup on the size of the baby, you could throw that in there. Ask directly in privacy with such questions at any time has a partner hit you, kicked you, or otherwise hurt or frightened you. And of course, it doesn't have to be stated exactly like that, so it doesn't sound like a canned question. Always document, 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 and document any information about suspected domestic violence or partner violence in the patient's record. And next, assess the patient's safety. Is it safe for her to return home? Find out if there's any weapons in the house, if the children are in danger, or if the violence seems to be escalating. So that, so if you're routinely asking about partner violence and it comes up, or maybe it's with the asking directly, it does come up, yes, something happened. Again, you're going to have to do that assessment and reassessment. And then finally, review options with your patient. Know about the types of referral options. So make sure you have a list handy of shelters, support groups, legal advocates, therapists, social workers, things that can help the woman immediately, help your individual patient without having to wait for them to come back for another visit or for you to call them. Other things that you can say to them that might help. Would you like to talk about what happened? Would you like some help? Instead of just pushing it on them. Ask about it. It is important. There are people that are in this situation that feel as though it will increase their risk significantly to ask for help. And sometimes that feeling is completely valid. Make sure you validate her experience and emphasize the risk of violence to her and the baby. That it's not something that she's protecting her baby from because the baby's still in the womb, but the baby is still susceptible to danger, emotional and physical violence. Make sure she knows that no one should deserve to be treated this way. Explain that you can put her in touch with somebody who can help her. And acknowledge that change is a process. It doesn't always happen immediately. Make sure you follow the situation over time and thank her and support her for telling you, I'm glad you told me this and I want to help you stay healthy and safe. Let's make sure we bring this up at the next visit. Again, if it's an immediate need, it's not saying I'm going to talk about this at the next visit. It depends on the severity of the situation. So let's talk about some safe integrative or complementary treatments for anxiety and depression during the prenatal period. So for natural and complementary and integrative treatments, we've got the movement and body therapies, and we have the nutritional supplements and herbal pharmacotherapy. And so the movement and the body therapies are the ones that are physical. They involve mindful movement, focused relaxation, stretching, massage, Reiki, and other non-traditional healing practices that work with your body, the somatic aspects. And then your herbal pharmacotherapy and nutritional supplements are looking at treatments that involve ingesting a formulated supplement or herb for the purpose of treating or aiding in the treatment of symptoms. So even if we're looking at natural and potentially alternative ways of healing and treatment, make sure it's evidence-based. So whether it's internal or external treatments, make sure that it's safe, evidence-based, and non-invasive. Just because something is natural doesn't mean it's safe. So integrative and complementary medicine, those are not usually considered part of Western medicine, but can still have positive effects as long as it's utilized responsibly. So body therapy, such as exercise and yoga, is actually promoted very strongly by Western medicine, even though it's considered integrative or complementary. Exercise is a way to naturally increase your serotonin levels and decrease your cortisol levels, stress hormone there. So it's vital to optimal health in pregnancy. It's actually been shown to have antidepressant effects, and it is recommended as part of an overall treatment plan for mental health during pregnancy as well as not in the childbearing year or the perinatal period. Exercise can also provide additional health benefits by reducing heart disease, obesity, diabetes, etc. There's evidence that yoga has an effect on reducing depression and anxiety disorders. Again, just make sure that the exercise is appropriate for prenatal. We're not going to go skydiving or mountain climbing. Massage has been known to increase relaxation and reduce stress during pregnancy when performed appropriately by someone experienced with prenatal massage, pregnant massage. It can also help reduce aches and pains associated with pregnancy, especially that round ligament pain, lower back, lower lumbar. Existing research has actually shown that massage can lower levels of cortisol and increase levels of serotonin and dopamine. Plus, it feels good. Aromatherapy, so is another alternative complementary method of treatment. Various aromatherapy oils have been studied for the treatment of depression and anxiety. During pregnancy, it's recommended that you use a diffuser and do not ingest any of the oils. Petitgrain can be used to promote relaxation and calm feelings. Peppermint oil inhalation has been found helpful with managing headaches and nasal congestion. Lavender essential oil is very calming, and when used with rose water has been shown to reduce depression in women at risk. That was actually a study at a hospital. And then clary sage can stimulate the uterus, so just be careful with that. It can be used with guidance, but again, it can stimulate the uterus to contract, so this should really be used with caution. Reiki. Reiki promotes caring and healing energy, universal life healing energy. There are some conflicting studies on whether the energy actually does have an effect or whether it's psychosomatic, but the good news is that there's been no negative effects from any studies. So it's safe for pregnant women and doesn't have any risks attached. Again, not many studies have been published on the efficacy of the healing, but the calming and the relaxing effects can still promote an optimal state of well-being. After a session, many individuals do report that they feel more centered, rested, grounded. And this is important, especially during pregnancy. At a hospital, Hartford Hospital in Hartford, Connecticut, they conducted tests in a clinical setting to see if Reiki actually had a documented effect, and they saw that it reduced stress and anxiety during pregnancy by 94%. It reduced pain by 78%, nausea and morning sickness by 80%, and quality of sleep by 86%. So really good numbers. Meditation. So meditation, again, even though it's typically not considered part of traditional Western medicine, clinical medicine, it's actually considered Eastern or alternative medicine. But there are a lot of studies that show that meditation can actually help to release endorphins without working up a sweat. So those releasing endorphins, especially for women that can't exercise because they're on bed rest or they have other physical issues during pregnancy, this is extremely important. It's recommended that an individual do abdominal breathing, deep abdominal breathing, for about 20 to 30 minutes a day to help with anxiety. It also helps provide more oxygen to the brain and stimulates the nervous system. Meditation can help to refocus, calm down, and clear the mind of any intrusive anxieties to better cope with any issues. So this is actually from a Harvard Medical School study, evidence-based complementary and alternative medicine with Harvard Medical School. Diet and nutrition. Even though it is considered a integrative treatment, it's part of preventive medicine, which is your typical conventional Western medicine, as well as lifestyle medicine and functional medicine focus on diet and nutrition, making a significant difference and having an impact during pregnancy as well as the postpartum period to help reduce not only the risk of depression and anxiety, but also if anxiety and depression are present, it helps reduce the signs and symptoms. So good nutrition, we know, is extremely important. Diets in high processed foods are associated with higher rates of depression. Diets rich in naturally grown foods that have been minimally processed, such as fruits and vegetables, have been shown to lower the risk of depression. They also protect against mood disorders, so looking from a preventive aspect as well. There are many foods that have been shown to affect the negative effect of the focus and mood, such as caffeine, sugar, processed carbohydrates, and additives. So it's important to look at your diet not only for the nutritional aspects, but also for the mood aspects of what it can do and how it can help. So when you are considering a risk analysis, risk-benefit analysis with the medications, it's something that is important to discuss with the patient if you are a prescriber or if you are working with a psychiatrist, and have signed a release and you want to talk with the patient again about the risks and the benefits of taking medication. So a lot of the risks associated with medication during pregnancy are perceived. The perception of risks and benefits makes a significant difference on whether a mother chooses to take for fear of birth defects. But they believe that it's safe to take an alternative or complementary treatment, such as a supplement or a tea or an oil, when in reality, the particular, depending on the alternative treatment, but it may be more harmful than prescribed medication. Again, that's something that can be explained. The psychoeducation is extremely important. Sometimes something like a certain tea or what have you can feel like it has more of an effect, but more of a positive effect in relaxation, but of course it could be affecting the fetus. So maybe balancing out, talk about, what are the types of natural relief that is healthy during pregnancy, and then also showing the individual what pharmaceuticals are okay to take and not have a negative effect on the baby. So although there are quite a few healthy, low-risk options, not all of them are effective, especially in most severe cases. So if there are signs and symptoms of depression, but not clinical depression, sometimes the individual can be treated with some alternative methods. But unfortunately, a lot of more severe cases have to be combined with medication. So, for example, a severe prenatal depression, counseling may help, aromatherapy, massage may help, but it may not get rid of the actual disease, because we're talking about a clinical diagnosis of a mental health disorder. So, if it is at that level, we do have to discuss other types of treatment. While doing that, while discussing this with the patient, know that the safety profiles and the risk profiles of most antidepressants are always being studied. And they're increasingly being improved. Per ACOG, the studies with the SSRIs do show that they do not increase the risk of birth defects, and this is the most selective serotonin reuptake inhibitors. And even the ones that have a slight risk do not increase the risk significantly. So general scientific evidence shows that antidepressant use has a very small increase. So this is of harm to the infant. Some studies have documented that there is neonatal withdrawal in infants, but the women who have taken this, that have had the withdrawal and their babies after, is mostly self-limiting and not life-threatening. So self-limiting, this means that it was able to resolve itself. The babies did not have to have any other external work, medication, or therapies. And again, not life-threatening. So while working with your patients and analyzing the risk and benefits, be sure to discuss the fact that many women who have had depression previously actually had a relapse of major depression during pregnancy. So when looking at it from a preventive aspect, this is an important fact to bring up. So statistically, there is a significant increase in having a relapse if a woman has been diagnosed previously. When treated with pharmacotherapy, less women relapse. So this is a good way to reduce that risk. It's also important to discuss the potential risks to the baby with an untreated mental illness, as well as having an impact on the mother's behavior and preparation. For example, a woman who is depressed is less likely to get good prenatal care and more likely to engage in unhealthy and dangerous behaviors. Here's some resources: Postpartum Support International, as well as National Alliance on Mental Illness, and SAMHSA, Substance Abuse and Mental Health Services Administration, which is a part of the Department of Health and Human Services. All of these have websites and helpline phone numbers that can be shared with patients, and they also have information that can help providers. And again, the following are references. This also includes some of the studies that I referred to in the presentation itself.